presentation after Sachin Tendulkar has batted. And with the kind of bamboozling presentation, pictures, diagrams that Dr. Jignesh has presented, uh, he's made my job a bit difficult, but I'll still try my best. Uh, Anyways, Dr. Jignesh and I have a very close association. We've been together at various hernia events since 2015. We've been traveling. We were at World Hernia Congress together. He's a teacher. He's one of those guys who's helped me in cases. I video called him in the past to make me, get through certain difficulties. So great to present in front of your own teacher, and perhaps I will try to do justice to the talk. So should I share my presentation? Yeah.
Yes, sir. I can see your slides. Can you just go to the... So yeah, that's great.
So good afternoon, everybody. The topic for discussion today is Etep repair for inguinal hernias. I bring greetings from my institute, Dayanand Medical College and Hospital. I have no disclosures to make. So basically going on to posterior approach to inguinal hernias, there are certain essentials that one needs to know. One needs to be very clear about the anatomy. One needs to have advanced laparoscopic skills, for example, with the kind of difficult choles, appendicectomies, a tap for beginners if you're moving from tap to the extraperitoneal space, a good HD lap set for recording all your cases and having a good vision, and perhaps recording would also help you to be to show it to mentors like Dr. Jignesh, and so that you can be criticized and you can improve on your work. So basically a review of the anatomy. We all know we have the pubic tubercle and then the Cooper's ligament. The common structures are the vas and the spermatic vessels. Then you have the iliac vessels in the background. Then the internal ring where your indirect hernias go. The epigastric vessels which form the roof of the and the iliopubic tract, and the nerves there. So this is the area where it is the extraperitoneal space, and you work for an inguinal for a laparoscopic inguinal hernia repair. So I read this new paper which shows which is by Ed Felix and his group about dividing this space into 3 zones. Zone 1 is the lateral zone, which is where the iliopsoas muscle and the nerves go. Zone 2 is medial to the inferior epigastric vessels, and zone 3 is our business area where the dissection is a bit difficult. So we can either start, if you are doing laparoscopy, you can either start with zone 1 and then move to zone 2, and then finally zone 3, and where you can dissect the sac and everything. Or either you can start with zone 2, move to zone 1, and in the last approach, zone 3. So laterally, as I told you, you have the iliopsoas muscle and the nerves in zone 1. Medially, you have the pubic tubercle, the Cooper's ligament, and your direct hernia sac. The central zone, zone 3, is where the vas and spermatic vessels and your indirect hernia sacs are. So another interesting concept was by Furtado. He published this concept which he called as the inverted Y, where you have the red is the stem of the Y, which is the inferior epigastric vessels. The two Y's V's of the Y are the inferior, the vas deferens on the medial aspect, and the spermatic vessel shown in blue. The iliopubic tract is the line which divides this into the upper zone and the lower zone. Anything above this, you have the inguinal hernias going through the internal ring and the direct sac. Anything below this is where you have the femoral hernias and the obturator hernias. So again, with this VY concept, you can divide, see all the triangles: the triangle of doom, the triangle of pain, the femoral hernias, the direct hernia, and the indirect hernia sacs. So Ed Felix gave these 10 commandments. I guess somebody needs to be muted. I have a lot of disturbance. So the 10 commandments of inguinal
Again,
hernia
can
repair.
you please?
So the 10 important commandments of inguinal hernia repair by Dr. Ed Felix is that one must see and dissect the entire wall, including the pubis, across the midline to expose all potential hernia sacs. If you don't see the entire floor, you don't have a proper dissection. You must be able to see the iliac vein in order to prevent missing femoral hernias. You don't have to expose it in total, but you have something covering the iliac vein until proven otherwise. You will miss a femoral hernia. Look for and dissect tissues lateral to the vas and gonadal vessels to identify little lipomas. The lipomas can appear tiny, but perhaps it is just the beginning of the lipoma, but it may be just the tip of the iceberg. You may need to pull the entire lipoma out. Dissect laterally inferiorly far enough so that the peritoneum does not lift the mesh up when it re-expands. All the techniques do not matter. It is not how you get there, but it's what you do when you get there. So make this place big enough so that you can have a transplanted kidney in place. You must dissect between the vas and the gonadal vessels to prevent missing the indirect sac. Pull it down till you see the vas turning medially, which is very important. The surgeon must extend the mesh to below the pubis, between the pubis and the bladder to prevent the bladder from lifting the mesh when it expands. Ideally, you should dissect from below up till 4 centimeter of the pubis, so that your mesh fits in well. If the bladder is empty when you do the case, you don't extend the mesh down below the pubes. You will be in trouble when the bladder fills up. Use a large enough piece of mesh to widely cover the 3 potential or actual sites of hernia. Barred extra large 3D mesh is a very good mesh for this dissected space. For most of my Eteps, I use the barred extra large. Completely and safely cover the entire mesh without leaving any holes or gaps. Pick the inguinal hernia repair or approach that is the best fit for the patient. In some cases, for example, if it is a cardiac patient, even an open Lichtenstein repair is good enough, or a tap or a TEP accordingly. Do not deviate from the principles from 1 through 9, whether you do any of the repairs that you are familiar with. Let's talk about the concept of Etep. The extended Etep technique is based on the anatomical principle that the extraperitoneal space can be reached from almost anywhere in the anterior abdominal wall. E stands for enhanced or extended view. This idea was conceptualized by a surgeon, Jorge Dias, from Colombia in 2009. It is basically inspired by all the limitations of the TEP procedure. I struggled through TEP myself. Initially used for inguinal hernias, and now we can use it for ventral hernias as well as lumbar hernias.